with that, I get the really good pleasure of introducing Dr. Omer, who is the director of the Yale Institute for Global Health and the Associate Dean of Global Health Research at Yale School of Medicine. He's conducted research both on the scientific side and on the behavioral side. He's done epidemiology of respiratory pathogens, of influenza, RSV, COVID. He's done clinical trials to estimate the efficacy of maternal and infant vaccines, but also critically, he's done clinical trials around interventions to increase immunization coverage. And it is really my great pleasure. I'm really looking forward to listening to your talk.
Thank you. It's my pleasure to be here. Sorry I couldn't attend yesterday's workshop. This is a broad topic that was given to me, and we have limited time. So there's no way I'll be able to cover all the aspects of this topic. But what I'll do is tell you a little bit of a story from my perspective, from my group's perspective, and we'll take the liberty of sharing my experience and my research group's experience in this group, while developing an undoubtedly incomplete list of lessons, which hopefully will become part of the broader set of lessons that we are discussing from this pandemic. So this I think was the first op-ed that came out around when what was called at that point the coronavirus outbreak. And the date was January 23rd, 2020. There was only one confirmed case of the so-called novel coronavirus. And this came out on the 23rd because I had tickets to Colbert on the 22nd. And so I wrote this op-ed on Metro North on the way back to New Haven, where I live. And the title of this op-ed was, "Is America ready for another outbreak?" And the answer was no. But I made the point that we were not helpless bystanders. We could do something about it. And there were three things that I emphasized, and there were three, if you will, warnings. The first one was, and what really concerned me as an epidemiologist was the fact that we were seeing cases in the US. I had no doubt that we will eventually see cases in what was happening in China throughout January. But I was surprised that we were seeing it early, and if you see them early, relatively early, and you see them in ICU for the first time or sort of severe cases, it's just the tip of the iceberg. So I'd seen other outbreaks. And so that concerned me. And so I knew that I couldn't predict that it will become a pandemic, but I knew that it will be a pretty substantial outbreak. And my first point was, let the scientists, and the scientists is broadly defined. Scientists exist in the academia, they exist at public health agencies, both at the federal and the state level and the local level. And the idea was let the scientists lead. It's not just, I wasn't acting like a biostatistician in an NIH study section, looking out for my own people. Well, I say that in jest to add a lot of value to the process. But it was, the purpose was to say that, the point was that this will evolve. And there will be substantial uncertainty around the outbreak. And the closer the gap is between the ability to synthesize new information and developing recommendations for decisions, the better we will be. The second point was that there will be misinformation and disinformation. And remember, this is January 23rd, 2020. And I said that there will be conventional sources of misinformation and disinformation, but this will be the first, one of the initial outbreaks in the period of mass social media. Ebola was another one, but we hadn't had a pandemic, although I wasn't predicting a pandemic at that time. But I also said, look, we have this new entity called preprint servers, which overall, I argued, I remain a fan of, of preprint servers. And I said that they are a force for good, but we have to be ready for some of the unintended consequences of the ability to post your work without peer review. The third thing I said was that politicians and our leaders will have the instinct to reassure. And there has been evidence to say that actually the public anxiety goes down if you provide reassurance, real or false. But in the long run, you lose trust of the public. Unfortunately, all three things turned out to be prescient. So since I'm a working scientist, and I think a lot of us see as our role, and especially academic scientists, even if we are not asked to do something, our role to contribute, I did some science around it. And I think in retrospect, a lot of us, and to be very honest, and if I look back, a lot of us who have been working on respiratory pathogens in one way or another, and relevant areas like vaccine acceptance and all of that stuff, it was a way to not just contribute, but have a little bit of control over the situation, or at least perceived control. And if you think about it, it isn't real control. You can't predict where things are going, but if you're doing something about it. So this was February 8th, as I recall, we fielded our first national survey. And we asked, we said that, look, leadership matters in these kinds of emerging situations. And we asked them about, fielded standard scales for trust in leadership and trust in source of information. And we asked about who should be in charge of America's, at that time, the question was coronavirus outbreak. It wasn't called COVID-19. And then we asked about source of information. And the first one was the director of the CDC. At that time, Tony Fauci wasn't a household name. At that time, people didn't have candles with his picture on it. People weren't wearing novelty socks with Tony Fauci's sort of image on them. And so nobody knew. We didn't even ask about the director of NIAID, but we did ask about the director of NIH. And look at where the president and Congress was in that list. This was the starting point of the American public. And look at the first one was, when we asked about trusted source of information, the first one was the least surprising part of our data. This is consistent, and you'll see that story again and again. The most trusted source of coronavirus outbreak, not just vaccine information, at that time we weren't talking about the vaccine, were healthcare professionals, followed by CDC, NIH. We asked that combined at that time. So people were asking for public health agencies to lead. And then social media was the last one in the list of things we had asked. We fielded this, another one in this summer for for monkeypox, as the news was breaking. We combined, for various reasons, we didn't separate out CDC in this specific analysis, but the trust in CDC has gone down since then. But overall, health professionals remain at the top, followed by health officials. And people come in. So this was a combined local and federal health officials. So as a class, there is a little bit of a misperception that all is lost, that public is overall distrusting of health officials, et cetera. So something to keep in mind around the monkeypox outbreak. So one of my colleagues and mentors, Walt Ornstein, who used to lead the National Immunization Program, was actually I was elected. I was fortunate to be elected to NAM this year, and he was one of my nominators. So Walt Ornstein, I don't know if it's supposed to be public information or not. I don't know. I'm new, so that's what I'll plead. So Walt says something very interesting, that a vaccine that remains in a vial is 100% effective, 100% safe and 0% effective. And some of us were asking these questions early on. So this was May 7th or something when we fielded this national study of asking about potential vaccine acceptance. This is May 7th or early May of 2020. This was before most of the phase 3 trials were started. These were a lot of phase 1, 2, or some early phase 3 trials were starting. And this wasn't our first rodeo. So I had been engaged with the response around H1N1, so we thought we should ask that question. And we said, using standard scales, we said that approximately 67% would accept the vaccine. Last night, this is the acceptance rate in the U.S. for COVID vaccine, the primary series, and the booster is sadly very low. And the other thing we said, look, what would be the determinants of acceptance? Because we refuse to be helpless bystanders in this kind of an outbreak, and so therefore we should figure out who would be more likely to decline this vaccine. And so we developed this model, this predictive model with pretty reasonable ability to identify who will not accept the vaccine readily. And it was age, gender, race, and education. Turned out to be the more important variables amongst a ton of variables. So if this was the more parsimonious model of this. And if you have been following the trajectory of COVID vaccine, this again, unfortunately, turned out to be prescient. And so this is May 2020. The preprint came out earlier, and the paper came out a little bit later in 2020. And so based on this, a lot of us are on the record saying, and this is from June 2020, and I wasn't the only one. There were a lot of people talking about it. But again, this wasn't the conventional consensus wisdom. A lot of people, a lot of very sensible people were saying, once we have the vaccine, since everyone was talking about the vaccine, people will accept the vaccine. And then there were very respectable people talking about we only need a few photos of physicians with rolled up sleeves showing that they trust the vaccine and everyone else will line up. Again, we were talking about, a lot of us, or at least a few of us, were talking about a systematic campaign. And there were examples of national communications campaigns. And we had a window at that time where the attitudes, and our data and other data showed that attitudes were not hardened at that time. It's really hard to persuade people once they take a position. At that time, attitudes around COVID vaccines were forming. And this is one evidence of that. Throughout the pandemic, I borrowed from other fields and collaborated with folks. This one was in collaboration with our colleagues in political science and economics. And what we said that, okay, what would be the implication? If you remember, there was a debate around when to authorize the vaccine, and there were some political dimensions of it. It's not a partisan statement because it's not part of the record, but there was some push, and FDA's politically appointed leadership resisted. And that's also part of the record, that there were some, not just career staff, resisted changing the schedule for authorization just to suit the political calendar. And so what we said, that we did these randomized experiments, and we asked potential eligible people that compared to, so the control condition was, compared to 1 week after the election, what would be their acceptance and uptake, of predicted uptake of this vaccine, if there was if the vaccine was approved 1 week before the election, or in December. So it ended up being authorized in December, around early December in the US. And it turned out we would have had substantial catering of confidence if it had been authorized before the election. So that standing up for the right thing and to letting the scientific process unfold had real consequences. And so this was the dog that didn't bark. Then we said, who does the American public trust? And so we had a series of experiments. This is a summary of this. And we said, what would be the negative endorsement and positive endorsement? A positive endorsement would be that someone believes the vaccine is safe and effective and says so publicly, or negative statement that they don't believe that vaccine is safe and effective. So remember, we're not talking about people on the left and pretty prominent people on the left in the fall of 2020 were not that certain. Now it has become part of the political identity, but at that time attitudes were forming. And what we found was the most effective communicator was Tony Fauci. And Democrats believed in what he said more than the Republicans, but even amongst the Republicans, he was the most trusted communicator in the fall of 2020. That's the baseline that we started with. And what about the politicians? The bottom line is to interpret that if Trump's endorsement, President Trump's endorsement, was beneficial for Republicans, but had a backfire effects on Democrats, and Speaker Pelosi's was the other way around. But if they said the same thing, they moved people on both sides of the aisle, but even they did not move people as much as Tony Fauci. And so this was the evidence we had. Then we did a follow-up of different groups, and we said that throughout 2021, the most intractable group in terms of persuasion, from a more technical perspective, were white evangelicals. And we said that what were their determinants for acceptance and what would move them. So these were a series of experiments that we did. And this is, there were clues for different interventions that I'm not going to go into. That these are persuasion interventions that actually focus on community at that time. Remember, at that time, we were focusing, there was uncertainty around whether there were indirect effects or only direct effects of these vaccines. But it turned out by spring 2021, this group, we had lost all potency of the conventional messages that we had. And that was concerning. So what happened between fall 2020 and 2021 was, and I'm not showing data there, and so there's some data here as well, that vaccination became part of political identity. And that's dangerous. A colleague of mine who's now in the government wrote an op-ed in Politico, of all places, 3-4 years ago, and we said that the worst thing that can happen to vaccines is that become part of people's political identity. And we were talking about, don't clump it with global climate change. It has, unfortunately, become a part of people's political identity. So then what was happening globally? And we did, with my colleague Mushfiq Mubarak, who is an economist, and partners around the world, we looked at data from 12 countries, 10 low and middle income countries, and the US and Russia. And we found overall in this study that in each of those countries, this is a collapsed output from all LMICs, but even in individual countries, the acceptance, so this is baseline acceptance right before the start of the vaccination program, was higher amongst all low and middle income countries compared to the US and Russia. But then there was a year throughout 2020, we had dismal vaccine supply. And this is how supply interacts with acceptance. In countries, I was working with UNICEF and other partners. In country after country, I heard that, look, we don't want to promote vaccines too aggressively because we don't have supply. And this is how supply and demand interacts. And now it's an excuse that these countries don't want it, but it's a pretty, if you think about it, it's not that irrational. If you don't have supply, governments do not promote these kinds of vaccines. And that gave, on the other hand, it was an open goal, since we are having a soccer World Cup. It was an open goal in a lot of these countries where they couldn't guard against misinformation and disinformation and natural questions that come up in this kind of a pandemic. So we have been right before the pandemic, colleagues at Gates contacted us to do, what was phrased as the mother of all reviews in terms of vaccine acceptance. What are the things that actually work? And it did overlap a little bit with the pandemic, and we found there were a bunch of things that worked, and I'll focus on them a little bit more here, that there were a bunch of things that were there that had evidence, actual evidence of working. And you would find that a lot of these things are conspicuous by their absence in terms of what we deployed as a country in actual intervention. So our interventions were not entirely evidence-based. And so there were heroic efforts by our health departments, our public health officials, to do their part in increasing vaccine acceptance. But frankly, at the federal level, where these kinds of things could have been deployed, now that for the last 6-7 months, there are efforts happening around these lines. But education campaigns, what specific type of education campaigns? On-site vaccination, this was deployed. Incentives, that was nuanced. Free vaccination, that was an important part of it. Institutional recommendation, that we have had a mixed record of that. Provider recommendation, this is one of the strongest effect sizes we see. And we haven't utilized our providers as a country to all providers recommend, but there's a specific way of doing this, is to actually train them to effectively communicate in the clinic. Reminder and recall system, message framing, vaccine champions is another one that we haven't utilized. And then there were a few other things. Things that were conspicuous by their absences or some nuances in these data that didn't surface was message framing, whether you positively framed or negatively framed didn't have a differential impact. And then incentives didn't work for healthcare providers. That was the evidence. And then decision aids that were helpful in other things didn't have an impact, and so on and so forth. Again, going back to our multi-country data, we showed that healthcare providers, the second, third, sorry, this is a bit small, but the first category is healthcare providers. It is consistently the most trusted source of vaccine information. And so some of us pushed for this, and we created, for example, a CME module based on the latest evidence of how to communicate in the clinic that we had actually evaluated based on some NAID investments after the previous pandemic. Our initial work was on OBs because maternal immunization was novel around H1N1. But then this work progressed. But I believe that we should have had a national CME program for vaccine communications in the clinic by healthcare providers. And then we worked with WHO, UNICEF, Meta, and a couple of other partners to develop a series of tools that were deployed in multiple countries. For example, a vaccine misinformation field guide, which has now been translated into 5 additional languages, a vaccine messaging guide, and then that is used by UNICEF country offices and other partners, and then WHO overall, beyond messaging, a vaccine uptake guides on behavioral interventions. And Peter, who spoke yesterday, and I co-chair the Lancet Commission on Vaccine Acceptance. It was a generic commission, not focused on COVID specifically, but we covered a lot of COVID stuff in that commission. The other thing is that it's not just vaccines. Non-pharmaceutical interventions are essentially behavioral interventions. And very earlier on, we utilized data. And this is, I think, March, April of 2020 when we started. We saw that there was access to anonymized cell phone data at an unprecedented level. And we showed, before Google started sharing all of that stuff of mobility, we showed, initially we had a preprint a couple of months after we started, and then 2021 we published the peer-reviewed paper that we took advantage of the differential imposition of stay-at-home orders. And we found that this is the anchoring of when this stay-at-home order or quote-unquote lockdown was implemented in each of the county. And this is minutes at home using anonymized cell phone data. We found that it shot up invariably. But then the question was it happening? Not all not all counties had that imposition. And the question was, would we, if we had not imposed these lockdown orders, would there have been a change in behavior either way? Because people were looking at, the news coming out of it and local and national news around COVID. And what we found, the bottom line was, actually, it was both the policy and the information that people utilized to change their behavior around mobility. And it turns out that people would have changed their behavior either way, but with shelter in place, it was almost equivalent to 20 deaths in a county on average. They did it a little bit early. So and this is the first set of shelter-in-place orders. And so the idea is that you save 20 lives on average, and this is a very, per county in terms of that effect. You saved more lives than that, much more lives than that. But in order to have the same behavioral effect on average, you had to have more deaths, et cetera. So what we would have been in a situation if there hadn't been these shelter-in-place orders where people would have reduced their mobility and impacted economic activity anyways without a fewer neighbors to enjoy the benefits of after the pandemic of resumption of activity. So it was both. And this is not a commentary on what is, later interventions. This was just the early part of the pandemic when entities are trying to sort out what's going on. We also, with colleagues at USC, we also looked at the pandemic fatigue and created an index of non-pharmaceuticals, and we found that we had a decline very early on in July, and stayed decline. And then within virtual media, we have been doing trials in multiple countries, and we found that it has been a very effective way of deploying quick messaging, and we found that we were able to change attitudes around vaccination. This was outside the US. And what we learned from that partnerships work, we have to have local languages, we have to focus on values-based messaging, and context, both domestically and internationally, is helpful. And we are now developing with Meta and at the Ad Council and UNICEF, et cetera, we have now a course to deploy those learnings. The other part is that national responses are inadequate. The fact that we pulled out as a country from the multilateral global health system in early 2020 meant that COVAX was left without resources. They couldn't place orders in time, and the supply was blocked. It is a simplified version of what happened. But that had implications. And as of fall 2020, we had shown with a few economists in Italy, again, the preprint came out earlier than the paper itself, that it was in the US's own interest to actually have a proactive, and this is not accounting for variants, et cetera. It was in the US's interest to have a robust vaccine access around the world. And then we proposed a pandemic trust fund. Our proposal was slightly different than what the World Bank ended up enacting, but I think there's more room for focusing on peacetime stuff. I was fortunate to be part of a NASEM committee for coming up with an ethical framework, not just ethical, but a framework which is based on science as well as ethics to say who goes first. And now we take it for granted. Who should be first? Healthcare providers, the elderly, et cetera. It wasn't. I know I was there. In our public hearing, there was very passionate and vociferous debate on who should go first at that time. I had the unique opportunity to be in the same role at the WHO. So I'm part of the WHO SAGE, but also specifically their COVID-19 working group, have been sort of developing clinical recommendations. But our first step was to say, what is the overall roadmap? And we published that experience in this, what happened. And I paired up the two people who led that process with a lot of colleagues who were part of that sub-working group, was Ruth Faden, who's another National Academy member. And what was different was this time, the science and ethics were well integrated. So we went back and forth almost seamlessly, drawing from both disciplines. And we developed, in both circumstances, especially for WHO, a mortality-first strategy. And when we evaluate that mortality-first strategy that ended up being implemented, sort of recommended overall in the US as well, so meaning that go for, not for transmission interruption, but the highest mortality risk groups, after the healthcare providers, because there was a special case because you had to, that was also focusing on mortality, maintaining the health system that has really quick second-order effects. We found that we just did this evaluation, and we found that it had a substantial effect. So states that enacted a mortality first or age-based prioritization had fewer deaths. And so these things have consequences. And we should do this in advance rather than trying to do it in the middle of a pandemic. We've been engaged in novel surveillance. I was fortunate to pair up with our School of Engineering colleague, Jordan Peccia, to be the first or one of the first groups to show actually that you can not only identify the RNA in the wastewater, but also out there in, you can predict it, use it to predict outbreaks as well. So it is not just a tool to identify, but to predict. And we said that the lead time is between 4 and 7 days, actually 1 to 7 days, depending on the situation. And I've been focusing on deploying it in situations where the wastewater is untreated. So these are data from Karachi, Pakistan, and we've been able to show that untreated sewage can be used for this. The other part of knowing is looking at how to count deaths. And one of the saddest projects that I've been engaged with is actually going to graves in one of the major metropolitan areas in the world, and to see verifiable data in places where is less documentation of data. And we are showing that both in 2020 and 21, there was excess mortality. And only a fraction of that was actually documented. And now we are doing it with remote sensing and seeing that freshly dug graves, can you identify remotely with this unique ground truthing data so that next time someone like me doesn't have to count graves? The other thing, I'll skip this part, and I want to emphasize overall that all sorts of outbreak science should be consequentialist. You should start with the outcome and work backward towards the discipline. And one example, again, I'm giving examples that I'm familiar with, that I was involved with, but this happened in most, if not all, academic medical institutions. So this was March 2nd, 2020, a bunch of us got together. It could have been a start of a joke, an epidemiologist, an immunologist, a clinician scientist, a virologist walk into a conference room, if not a bar. But this was March 2nd, 2020, and we said we need to work together. We need to establish cohorts that could ask policy-relevant questions. We need to look at newer ways of testing. And this group, so we just had this summer, had a happy hour of our mentees. It grew, and now there's a second generation of people who are now at faculty level very quickly that grew out of this collaboration that happened. This kind of collaboration happened in multiple institutions. And these are just a few examples of what came out of this consequentialist approach to science, where we all got together. So this is an incomplete, admittedly incomplete list of lessons that I, both as the director of an institute, but also as a working scientist who happened to have a few relevant parts of my portfolio that I deployed during this outbreak. First of all, do not take compliance for granted. And we shouldn't just be enamored by technology. Technology is essential but not sufficient. Invest early in behavioral research, and hopefully we'll talk about the actual federal investments or lack thereof and when they were needed. Virtual media has real consequences. We focus on negative ones, but there are positive ones as well. And it blows my mind that we, in the world of social media, we are bringing nail clippers to a gunfight. The other part is global engagement is enlightened self-interest. When Delta was going around, we have data, others have data, that there was indirect protection. We could have had a chance at interrupting actual transmission. With Omicron, we don't talk about that. Our data show that there is some much lower level of indirect protection. We had a chance to break and substantially control infection as well. And the fact that countries where this was running rampant without much vaccine supply, we had to pay consequences. and part of it shouldn't be just self-interest of a country. It should be being part of a world where we exist in this time. But even if you just look at from the perspective of narrow self-interest, and we showed that in November 2020, that it would be in the US interest to heavily focus on global vaccine equity. Connect to people's values, invest in novel surveillance, and this time we better have our act together the next time this happens, and all sorts of surveillance, both behavioral surveillance, but also mortality surveillance, sewage surveillance. Facilitate collaborative research before the pandemic. Look, a lot of the initial work that I did with sort of Akiko Iwasaki's group or Albert Ko or Nate Gruba's group, we self-funded. The fact that we had endowed professorship is a huge privilege, but it shouldn't be. We have no monopoly on ideas. And imagine how many ideas, interdisciplinary ideas, were either late or never came to surface because they were dependent on an antiquated funding model that is not suited for public health emergencies, especially for collaborative research. Ethical considerations should be and can be baked into decision-making. Vaccine interventions, acceptance interventions should be based on on-the-ground experience. Some of the best interventions were due to local innovations that health departments were doing. But at the same time, we should also focus on rigorous vaccine acceptance science. And the last thing is the time to innovate around policy is now, when it is not the cool thing to do, when it is not that gets you on TV or NPR or on the front page of the New York Times. Because if not us, then who? Thanks.
Thank you so much for that. That's fascinating. So I'm going to ask only a couple of questions because I'm hoping the group has questions, and I want to be sure everyone gets in questions. Speaking about the investment, from the outside, I feel like there's a hierarchy in pandemic science and pandemic work of basic research, translational research at the top, and then behavioral science somewhere out in the corridor asking to get in the room. So in terms of going forward with investment and also us working on the hierarchy as well as the money, what should we do?
I think we should.
Yep, just press.
Otherwise, I can use my stage voice. I think we should not be surprised. So there were very well-respected leaders who, in their exit interviews, said that that's one of the things they were surprised by, that how the vaccines would not be accepted. But why was that a surprise? There were people, not just us, saying that in advance. There was evidence. There was evidence from the sort of the Kaiser Family Foundation survey. There was evidence from all sorts of places that we can't take it for granted. So we need to recognize it here. And I'll give you the reason why I'm able to do this kind of work is most of my funding comes from vaccine trials, vaccine epidemiology, and all sorts of other stuff. For years and years, vaccine acceptance science, especially the science part of it, has been a labor of love. I'm now funded based on that because that's the nature of our funding mechanism. Once you do the stuff, then they give you money for the next steps, for the incremental step, not for the groundbreaking stuff, especially in this part of science. But we shouldn't do that. We should acknowledge that that NIAID, the first time I got funded from NIAID on a vaccine acceptance project. Well, the first time we submitted an NIAID R01, that was early 2000, the first review comment was objecting on the first sentence of the application that said vaccines are one of the most effective interventions, public health interventions. That was the big objection. So there wasn't, it went to a study section that didn't know where to place the study. Those basic mechanics of encouraging this kind of science during the pandemic, I'll tell you, it's not that NIH doesn't have the muscle memory of doing good, solid, and funding. And I'm just, the reason I'm focusing on NIH is because NIH is the biggest biomedical funding agency in the world. NIH does and funds solid behavioral sciences in HIV. National Cancer Institute, and this is NIID, National Cancer Institute funds some of the best behavioral sciences that is out there. Within NIID, I think there has been a change, and there were leaders, internal leaders, who convened during the pandemic. But the fact is that it takes time to build that, for that recognition, that policy documents to be actually translated into action, et cetera. So hopefully we'll see that, but that's the bottom line.
And I'm going to ask one more question, and I'm going to then give it to Dan. I'm going to ask one more question, then I'm going to let Dan ask a question. So I think the world over, one of your slides addressed that healthcare professionals are the most trusted communicators on vaccines, on other healthcare issues. Wellcome Trust is a big study that it's also shown the world over. So backing up from what I think is an incredibly good action item of a national education campaign for practitioners is how are we doing in educating our medical students and our nursing students about communication on health issues with their patients?
So, look, one of the most concerning studies I did on this topic was in early 2000s, where we showed that there was a cohort effect on vaccine acceptance compared to early graduates versus late med school graduate. So the hypothesis was that if you were a trainee, a med student, a resident in the 80s, and if you saw a case of Haemophilus influenza type B walking through your ER, the kid was probably okay last night, but could die without pretty substantial intervention, that stays with you. And we said, we know that physicians have really high vaccine acceptance, both as people who vaccinate their kids, this was childhood vaccination at that time, but also, as recommenders. But were there some early trends? And we saw those trends. And so if you are not seeing it, and that, vaccines have become, a victim of their own success, and this is part of the story. And I know Dr. Larson is talking about a lot of other nuances there, but this is part of the story. And based on that, I think we need to act. There have been model curricula, there have been modules that are there that have been developed by colleagues over the last 10, 12 years. But I think we need to do a little bit more. And we need to do it based on evidence. Vaccine acceptance science is not amateur hour, especially when you're training physicians. Why do we don't tolerate fluff when we are teaching pathology, at least not anymore. But why do we tolerate fluff when we are teaching vaccine acceptance science?
Dan, you want to ask? Yes, hi, is this on? Dan Baruch from Beth Israel Deaconess Medical Center. Thank you for your fascinating talk. I love your analogy of bringing a nail clipper to a gunfight. I really think that a lot of doctors and scientists are outgunned when it comes to the social media or communications aspect, and I think we're largely not as knowledgeable as we should be in terms of how those dynamics work. But my question is, in your talk, you outlined very clearly what the attitudes were at the beginning when the vaccines were just coming out, when public fear was at its highest, and when expert opinion was fairly united. How did that change over time? And in particular, at least one of my own observations, being in the sort of the fray of the process for the pandemic, is that it appeared that expert opinion was no longer united as time went on. Just one example, in August of 2021, when the White House announced that there would be boosters for all available in 1 month, then there's notable departures from the FDA. There's pro-vaccine experts on prominent media objecting to government policy, CDC and FDA and NIH not aligned on messaging. And how does discord amongst us impact the debate?
A very good set of questions. First of all, in the interest of time, I didn't present later data, but things got worse. And Heidi, who's later in the day, has done some fascinating work on sort of serial cross-sectional stuff around the world. Hopefully, she'll share some of those data. Our data showed that part of the reason, and now focusing on the US, global data is a little bit more nuanced. It was partially because it became part of the political identity. It wasn't that the next time around, look, hindsight is 2020. The next time around, if we are rolling out a vaccine, we should make a concerted effort to ensure that it is recognized as a national campaign rather than aligned with any administration, et cetera. So that's a lesson we should focus on. A lot of the briefings, we are a democratic country, and so therefore political accountability and political credit is part and parcel and is a healthy part of that, our society. But if you take credit too early, that can alienate the other side, and it goes both ways. And we showed that in terms of looking at the individual data before the pandemic, and that played out. By spring 2021, some of the most challenging groups, like nothing was working. We tested it out in randomized trials. And so therefore, the next time around, we should have an evidence base to start with. We should focus on, and I think the good thing happened that our opportunity was before the season that we took a bit of a breather from discussions around, the public discussions around vaccines and vaccine acceptance, and that would have been an opportunity to stand up a healthcare provider focus infrastructure where we're reducing missed opportunities. A cardiology visit is a vaccination visit, and all sorts of things. So that's it became part of the political identity, and perhaps next time around there should be more messaging directly from the CDC. People in public health service uniforms, like we did for anthrax, like we did for Zika, like we did for Ebola, less from DC. Some from DC, but more from career folks at the CDC. And so that's one thing to go back, and that's true that would have been helpful from 2020 onwards, et cetera. So your question, sometimes, look, I'm sure, and I know, like you're a prominent scientist, you've served on committees, et cetera. There's always disagreement, et cetera. And that's part of the healthy debate. I haven't been right 100% of the time. Every scientist evolves their views, et cetera. This time what was happening, and so some of it was, so the debate, I know what the couple of examples that you're talking about from, I think you didn't mention the committee, but I think that started at VRBPAC and then came to the public square. Look, these were genuine scientific back and forth as part of it. I don't think we should eliminate that. That's part of having trust in the system where you have not everyone, the fact that people have discussion and votes and open committee laws require us to have that open conversation. I think one thing we should do, so agreement between actual experts is part and parcel of it, and I don't think we should even try to eliminate that. I think we should message around it better in terms of that this is part of scientific uncertainty, and those who are disagreeing, perhaps next time around, do it with, I'm not saying that they didn't have humility, but we should all do it with a level of humility, and to say that these are uncertain times. So that's what I would differentiate. But because, look, this is a time of uncertainty, and sometimes, I serve like every Thursday morning, and today we got a break. Every Thursday morning, I wake up at 5:30 in the morning and dial into the WHO COVID-19 vaccine working group call, and we have a back and forth. And then at the end of the day, there's a statement that comes out of it.
Okay, on the right.
Thank you. Can you hear me? This is working?
Yeah.
Okay. I'm Matt Zahn. I am a practitioner at a local health department in Southern California. Dr. Omer, very much appreciate your presentation. As a local public health practitioner, I am very, very well aware that public health communication fell short. We just didn't get where we want to be. I think a second frustration for me would be that, a couple of years into this, really, if a new health officer or a new public information officer was to be hired at a local health department and come to me and say, what is it we did wrong, and what are the things we should do differently to do better? I don't know that there's clarity there. There are a lot of comments about what happened, but the next time, in public health, we hate toolkits, but we really need a toolkit. And you can't be too specific about it, but it is, what are the principles about how we communicate uncertainty, how we communicate what initial shortage of materials? What are we supposed to be, what should we do differently? And I think you referred to some documents, but any comments you'd have on, one, what the resources out there to do that exist to do that, and two, how public health and generally we can come to understanding public health and the community, the world. What is it we're supposed to communicate? What's reasonable? Comments you'd have on that?
Yeah, so we have, first of all, a few, set of documents, et cetera. Although we did a lot of it with UNICEF because they're the main communicators in a lot of countries outside the US, including in the Euro region, they have a pretty strong presence, et cetera. But I always had in mind that it should be translatable to all sorts of situations. So that's initial draft of it. Going forward, we are working on it. So this is, the evidence is not there 100%. But we are hopefully bringing some humility to it to say that we don't know 100% yet, but we are getting there. So we did a series of interesting experiments that I didn't show in the interest of time, when we asked people, a lot of people say that, I'm doing my own research. So in an experimental situation, we challenged them and showed them that their research was wrong. And we looked at that effect of that. A lot of the work that is coming out, and it was actually bimodal. If you were vaccine hesitant, you went on the other side. If you were a pro-public health, you went, do your own research moved you so quickly towards increasing trust. And so, but these kinds of things, that's our job to do it, but our job to translate it as well. The other thing we have been doing is values-based messaging. And some of the most promising things we are finding, again, I like being an interventionist, and to say, what works, we are finding that if you speak, it is not our place. It is not my place to try to change people's values. But if you speak to their liberty values, if you speak to their purity values, that is very promising. But coming back to broader public health, I think, first of all, and this is specifically what my focus for the next 2-3 years is, what are the things that can increase trust in public health, because we are all worse off if our public health agencies, especially, so look, there is still trust in local officials. Like, we show that it's specific officials. And so there's good news for folks like you, and it's no accident. But there is a deficit of trust at the federal level. The first step is our public health entities should be trustworthy. And we should have the best science. We shouldn't try to, it shouldn't be I'll give you an example. There has been evidence that removing isolation in the Omicron era after 5 days hasn't been supported by science since early 2022, late 2021. I have seen the data have been published, et cetera. So this is just one example. The fact, so in terms of masking and sort of modes of transmission, the problem wasn't in March, April, May 2020 when we went back and forth, because people were looking at the latest science. The problem was that we don't have a mechanism to do trials of masking, large trials of adequately powered, tens of thousands. I've done sample size calculations for that. It would require tens of thousands of people. Every season we had coronavirus outbreaks. Every season we had flu outbreaks. And we didn't do N95 trials. We didn't do KN95 trials. We didn't do surgical mass trials, et cetera, before the pandemic. So for us to be trusted, we have to be trustworthy first. And then there are 2, 3 other things. We are finding promising clues in transparency, but directed transparency, trusted messengers, but that's a very limited cachet. People stop trusting people irrespective of who they are, if they are doing a certain set of things. But this is emerging set of evidence.
And I'm the bad bearer of news that we need to move to the next panel, so you stay. And